So let's assume that these have all been established: analytical validity, clinical validity, and clinical utility. You know that you can measure the genotypes accurately. You can predict well the phenotype of the patient based on those genotypes, and there is something that you can do about it. You can alter the outcome of the patient if you know these test results. Given that, what is a clinician supposed to do at this point? So they don't have the time or often the expertise to know how to interpret test results or what to do with a patient's dose. Okay. Even if the test can tell them that the person is at increased risk for a particular side effect, they don't know exactly what it is that they're supposed to do. That should they not give the drug? Should they decrease the dose, increase the dose, what? So the value is that, of a guideline which can give specific instruction based on test result is very high. So then the clinician feels comfortable, okay, I get a test result, and now I have a formula that I can check, and I know exactly what to do with my patient now. So that's why clinical guidelines are so useful. They are kind of the final step, in a way, in implementation of pharmacogenomics. So I'm going to talk about one group. I've mentioned in other segments. I'm going to talk about them a little bit here, called CPIC. Their goal is to write guidelines about how to use genetic test results to optimize pharmacogenomic therapy. Okay? Their guidelines are peer-reviewed and published in the journal CPT, and they're posted on PharmGKB. This is an example of one of their guidelines. They give specific test results, like specific diplotypes here, with dosing recommendations that give you exact dosages, like start at 30 to 70% of a full dose, or use an alternate therapy. So very specific things about what to do in this case. These guidelines are published as manuscripts, but can be converted into tools that a clinician can use to just quickly enter a genotype and then see the result. So this is, for example, a tool on PharmGKB. It's a drop-down menu where someone can enter a genotype of a genotype result of a subject. In this case, we're entering star 3A and then a star 1. I'm going to select star 1 in this pull down. Once I do that, this pops up, this message pops up with the exact recommendation from the implications for what this genotype means, the predicted phenotype for that patient, and specific drug dosing recommendations from that guideline. So that's how you can take a guideline like that. Again, it's published in a manuscript form, so even though it has specific to-do instructions for a clinician, most clinicians aren't going to have the time to sit there and read through the entire paper. But if you could take the guidelines that are peer-reviewed and published in a manuscript like that and make it into an app or some kind of interactive display where a physician can enter a particular genotype and get recommendations right there, it helps lower that barrier to implementation. The CPIC guidelines, this is just a list as of October of 2015 of the guidelines that have been published. There are other drug gene pairs planned, and you can go to this URL to see more of the ones that are planned to be written in the next year or so. There's another group called the Dutch Pharmacogenetics Working Group. They are a group of Dutch pharmacists that have come together and evaluated over 50 drugs, 53, I believe, drugs that they looked at to look at how you could use a genotype information to dose those particular drugs. They actually did this before CPIC was even started. They have a couple publications out. It is part of the reading for this segment. And these papers, there was an original paper in 2009 and then an update, I believe, in 2011. And again, gives very specific recommendations for dosing based primarily on pharmacokinetic parameters. So this group is a pretty awesome group. It's pretty amazing. In the Netherlands, they have this association where pharmacists, physicians, pharmacologists, et cetera, come together, and they have their pharmacy network is countrywide, and they're able to implement these guidelines across all the pharmacies in the country, which is pretty cool. This is an example of one of their recommendations. Again, they have what the genotypes may be. This requires a little bit more work on the reader's part because they have to look at the test result and then see which bucket their patient falls into. But then it does give them instructions about how to alter the dose, and then also evidence. What evidence was this recommendation based on? Okay. I'm going to skip this slide for a second because it's out of order. So in addition to clinical guidelines, there are some recommendations for dosing on some FDA labels. There's not a lot, but there are FDA labels that include pharmacogenomic information. There are more and more of these every year. As an example, in 2011, there were only 14 drugs with this kind of information on the label. And in 2012, there were over 100. And now there are, I don't know, well over 100 of drugs with this information on the label. If you go to this URL, it will take you to a table that the FDA has put together of labels where they have identified some kind of gene or gene product on the label itself. The table looks like this. You have the drugs along here. You have what kind of, what gene is involved, is mentioned on the label, and what section of the label the gene mention is in. On PharmGKB, there's a list of all these FDA labels from that biomarker table, and they have annotated the labels with if the label says genetic testing is required, if it's recommended, if it's just informative type. They just mention that the drug is metabolized by a certain gene, but they don't give any recommendations for actually testing. It's annotated. So there are quite a few FDA labels where genetic testing is required on the label before prescribing that medication. But there are a lot more labels, as you can see here, where they don't give any requirement for testing, but there are dosing guidelines written by either the CPIC or the DPWG group. So there's some valuable information on the drug labels, but the dosing guideline groups take it even further and address more drugs where the FDA may not give clear instructions on or recommendations on how to implement. Okay, so I'm going to talk about some places now towards the end here of our lecture where these are healthcare systems where they actually are implementing PGX in the clinic. So there have been segments on like kind of classic examples in PGX. I've talked about examples of cancer PGX, different clinical guidelines where involving cytochrome P450s, and some combination or some subset of those, all those different PGX associations that have been discussed in these segments are being implemented in these different research facilities. They're all over the country. They're scattered around the US. There are more than this. This is a non-exhaustive list, but this is some of the I would say, most prevalent or most well-known institutions where this is being implemented. And I have URLs here on the slide. You can go to these URLs to learn more about any specific program and what the gene-drug pairs are that they're implementing and what variants they're testing for. Of note is Vanderbilt University. The hospital at Vanderbilt University has an opt-out program for their patients, which is different, I believe, than any of the others listed here. And that is to say that all the patients that come through Vanderbilt Medical, the Vanderbilt Medical Facility, are automatically enrolled in a program to be preemptively genotyped, unless they opt out and say that they don't want to be a part. Most programs have an opt-in procedure, so that one's kind of unique, and they have a very, as you can imagine, a very extensive database of genotypes used primarily for research originally purposes, but now some of that research is starting to be moved back into the clinic, and they're implementing some of these pharmacogenomic tests into their routine procedures. And one way that these large, you can see these are all large medical facilities and somewhat research focused as well. But what makes them, what gives them the ability to be able to implement these programs is their clinical decision support in their EMR systems. So most all of those hospitals listed on the previous slide have clinical decision support that they're building into the computer system that the clinicians use on a routine basis. So every time a clinician is dealing with a patient, they type in this information, they pull up the patient record. They're automatically alerted already to things such as drug-drug interactions. A lot of even primary care doctors have this in their facilities as well. So if they go to prescribe a patient a medication, they type it into the patient's record, and they're automatically alerted if the patient has an allergy, say, to a particular drug. A pop-up screen comes up. Some pharmacies are where you would see probably more of the drug-drug interactions, but also in some healthcare facilities too. So if the patient is already on a medication where there's a known drug-drug interaction with the medicine that's being prescribed right now, an alert comes up. So you can imagine a scenario where the same thing would happen if the patient was preemptively genotyped, their genotypes are already in the medical record, and the doctor goes to prescribe a drug that may be affected by that particular genotype. It's the same type of situation where they go to enter the drug, they type it in, and then an alert pops up and says, your patient is a poor metabolizer for this particular drug. Do you want to go ahead and prescribe this drug, or do you want to prescribe an alternate drug, or do you want to change the dosage? And so this is an example of an EMR record where you have some genomic information right here for clopidogrel. Say this person is a poor metabolizer, has it in big capital letters, what the gene result is. And so if that's already in the medical record for that particular patient. So if a physician types in a prescription for clopidogrel, a message can come up and say, genetic testing has been performed and this patient is at risk, and what would you like to do? And I don't have all the steps, we don't have a screenshot of all the steps, but in most of the places where this is being implemented right now, the doctor has the ability, obviously, to override any kind of suggestion that's given. They can continue with their clopidogrel prescription, or they're given some alternatives, and they can select from that list. So having that kind of clinical decision support is very valuable for moving pharmacogenomics into the clinic setting. And so every CPIC guideline that is published now has a table in the supplement where they provide not only the genotype and predicted phenotype for that particular genotype, but they have actual text for what you could put in your clinical decision support system that should pop up whenever a patient with that particular genotype and diplotype is prescribed the medication of interest. So we're going one more step to try to push the information into the clinic setting. So overall, talking about going from analytical validity all the way to integrating this information into the EMR system is basically a summary of what it would take to implement pharmacogenomics and get it moved into the clinic.